Hi everyone, I'm Ellen Cummings. Welcome to Block 4. I'll be team teaching the Med-Surg section of our class along with Tiffany Knudsen. My very favorite topic is cardiac, and I hope that you're as excited to learn more about what a wonderful organ the heart really is as I am to be able to talk to you about it. This narration will take you through the first part of the EKG packet. It's actually divided into two. We'll have a preclinical lab part 1 and preclinical lab part 2. The objectives, this is the objectives for the entire packet. We're going to start out and do the first part of the packet in these two narrations that you're going to be viewing, and we'll finish the rest of the packet when you're at Gateway and Preclinical Lab. So the objectives of the entire packet are: describe normal sequence of electrical conduction in the heart, identify some EKG waveforms, a P wave, a QRS, and a T wave, analyze strips and identify the following rhythms. We'll be looking at the sinus rhythms, atrial fibrillation, supraventricular tachycardia, VTAC, VFib, asystole, heart blocks, and paced rhythms. We'll also be talking a little bit here about the hemodynamic effects and management of rhythms. Those are also something that we cover pretty heavily in class too. Just a little bit of a review, kind of refresh your brains on cardiac. When we actually focus on the electrical conduction system of the heart when we're reviewing EKG, but electrical conduction is only part of actually moving blood forward. We do need electrical stimuli, and that's what we see graphically on the EKG, but we also need a working muscle and parts. So let's just do a quick little refresher of the parts. Remember that atria are reservoirs for the ventricle. You remember that the heart has right and left chambers. The right atria collects blood that will move into the right ventricle during diastole. Left atria is collecting blood to move into the left ventricle. Atrial chambers are very low pressure, and they really just serve as reservoirs for their respective ventricles. Ventricles are the pumps. Now, right ventricular contraction, as you know, pushes blood into the pulmonary vasculature, and the left ventricular contraction pushes blood into the aorta to perfuse the body. Now, the heart is a relatively small muscle. It can't do all of that work by itself. In addition to the contraction, the muscle, blood also flows through the body because of pressure gradients. Blood flows from high pressure, and that's the left side of the heart with the left ventricle and throughout the arterial system, to low pressure, and that's the gradient, and that's the venous system and the right side of the heart. So the right ventricle is a low pressure chamber because it doesn't have to work very hard. Pressure in the pulmonary artery is very low. Typically, mean pressure in the pulmonary artery is somewhere around 7 to maybe 15 millimeters of mercury. Because of that, the right ventricle is just a thin tube of muscle. Now, the left ventricle is a high pressure chamber. It has to generate enough pressure to move volume forward, and that's the biggest portion of the heart muscle. That we know the left ventricle is pushing oxygenated blood through the aortic valve into the arterial system, and that mean arterial pressure in the arterial system is anywhere from normally about 65 to 105 millimeters of mercury. So need a lot of push. We also have valves that keep blood moving in a forward direction. We know that the atrioventricular or AV valves are the tricuspid and mitral valve. When you're listening to the heart and you're listening to lub-dub, our S1, S2, we know that the lub, the S1 sound, is produced by closure of the tricuspid and mitral valves. The semilunar valves are the pulmonic on the right and the aortic on the left. Closure of the semilunar valves creates the dub, or that S2 sound, when they close. Now, systole is occurring between S1 and S2. Remember also that the heart muscle itself has to have an oxygen supply, and that's through the coronary arteries. It's important to remember that the coronary arteries supply oxygen to both mechanical and electrical structures. What do I mean by that? Mechanical is the heart muscle itself, the myocardium. The electrical structure is the specialized cells within the myocardium that we're going to be talking about as we talk about EKG. So we have to remember that if there's a problem with the coronary arteries, for example, a heart attack, not only is the myocardium, the pump itself, at risk, and of course that's going to affect our pumping ability and our cardiac output, but electrical structures are also at risk, and that will affect conduction, and we'll see EKG changes. We don't get contraction without the ability to conduct electricity to the myocardium and create the stimuli for contraction. Another thing that we have to remember is that 75 to 90% of coronary artery filling happens during diastole, the resting phase of the ventricles. That's when the ventricles are filling and pressures are low. That's important when we look at patients with high heart rates. We don't have as much time to fill the ventricles, and so cardiac drops and perfusion to those coronary vessels also drops. Quick review here also, we established that blood moves in a forward direction, and it's helpful to remember the path the blood flow takes. If you've got this in your head, it's going to help you when we're in class and we're talking about right and left heart failure and valvular issues and things like that. If you were monitoring a little red blood cell that's traveling from the lower extremity up through the inferior vena cava, it's first going to hit the heart at the right atrium. From there, the blood cell is going to pass through the tricuspid valve into the right ventricle, then through the pulmonic valve into the pulmonary artery. And remember, the pulmonary artery is the only spot in the body where an artery carries deoxygenated blood. From there, that pulmonary artery is going to travel to the capillary network and around alveoli for gas exchange. Next stop is for that oxygenated red cell is to go from that gas exchange to the pulmonary vein and then to the left atria. From the left atria, the cell passes through the mitral valve into the left ventricle, then through the aortic valve, to the through that into the body. Now, remember, as I said, remember this when we're talking about heart failure. So, for example, if your patient has left ventricular heart failure, the left ventricle is not pumping very well. Less blood is going to move forward, so more and more accumulates and backs up. Kind of like what happens when your toilet clogs. You flush, and instead of disappearing down the drain, stuff winds up going backward. If this is your bathroom, it's all over the floor, and that's disgusting. When it's your left ventricle, the extra fluid accumulates in the left atria, then in the pulmonary vasculature. Those vessels get engorged, and because of pressure gradients, higher pressure, they leak fluid into the interstitial tissue around alveoli. Then once again, as we have more fluid in that tissue, it creates a pressure gradient and fluid moves into alveoli. And what happens there, your patient is hypoxic, they have crackles, they're not feeling so great. So the heart is a pump, but it can't work without electrical stimuli. So we're going to be talking about that. The conduction system of the heart. Electrical stimulus causing cardiac cells to contract is what the conduction system of the heart is all about. When you look at this picture, you see those lines here that are talking about conduction, and it makes it appear that there are cells that look like wires running through the heart. That's not what you're actually going to see in the myocardium. When we talk about the conduction system, we're referring to specialized cells that carry an electrical signal. That signal causes what's called a wave of depolarization that stimulates myocardial cells to contract. Normally, the electrical stimulus starts up here at the SA node. Now, that's also called the sinus node, it's the sinoatrial node. It's also called the sinus node or SA node. We're going to stick with SA node. Now, it's the heart's dominant pacemaker, and its pacing activity is what we know as sinus rhythm. When you have a sinus rhythm, the initial pacer started at the SA node. The cells of the SA node have a property called automaticity. Notice that, as I said, the SA node is located in the upper posterior wall of the right atrium. I'm looking at the wrong thing. I'm looking at two things at once. The SA node initiates that electrical impulse at regular intervals, generally a rate of 60 to 90 beats a minute. That electrical impulse spreads through the atrial chambers, the myocardium, kind of as a wave, like if you were to throw a rock into a lake and you would see this circular wave. Now, that circular wave is creating depolarization. Basically, it's a wave of sodium that moves into cells, and that should stimulate contraction. When we look at this on the EKG, we see this as a P wave on that EKG. Now, the AV valves, and it's not pictured real well here, the AV and the semilunar valves actually sit on a plate of fibrous tissue that divides the atria from the ventricles. So that's a good thing, because we don't want a bunch of impulses from the SA node to be able to just jump directly from the atria to the ventricles. Now, the atrioventricular valve, or AV node, And so we've got that here. That's going to take that wave of depolarization and distribute it to the ventricles. So the AV node does that, and it also protects the ventricles. We have a bunch of built-in fail-safes for our heart. How does it protect the ventricles? Two ways. One, the AV node will hang on to the impulse for just a fraction of a second, and that's a good thing because that little pause allows the atria a little more time to finish contracting, so we get a better fill. The AV node also protects the ventricles from really high atrial rates. When we talk about atrial fibrillation, there's a bunch of kinetic electrical impulses that are just firing away willy-nilly in the atria. And because of that, the atria just quiver. We don't get contraction. Now, it turns out you can live with a quivering atria. We still get volume in the ventricles because of pressure gradients, but we can't live with a quivering ventricle. That's called VFib, and that basically correlates with dead. So the AV node doesn't send all those impulses to the ventricle. What it does send through goes in an irregular pattern, and we'll talk more about atrial fibrillation later on. So protective mechanism. And there's another way that is protective too that we'll talk about. From the AV node to the bundle of His, and so we got AV node, bundle of His, and then you see this bifurcation into the right and left bundle branches. Now, the bundles in bundle branch refer to bundles of these rapidly conducting Purkinje fibers. The picture makes it look like the Purkinje fibers are, kind of a separate thing, but this is actually bundles of Purkinje fibers that just kind of branch out into the myocardium. That impulse spreads through the ventricles very rapidly, causing the wave of depolarization. Contraction should follow. You'll notice I keep saying should. Just because there's electrical conduction, there is no guarantee that we'll get contraction. Quickly, some of the physiologic properties of cardiac cells, because this is some terminology that we use when we talk about, electrical conduction. I mentioned automaticity when we were talking about the SA node. The SA node is capable of initiating an electrical impulse, and it's normally the pacemaker of the heart, the captain of the ship. But what happens if the SA node fails? That can happen. Fortunately, though, as I said before, our heart has some built-in fail-safes. If the SA node fails, a portion of the AV node called AV junctional tissue can actually take over as an automaticity foci. It's not normally as fast as the SA node. Typically, that AV nodal junctional tissue is going to pace at a rate somewhere between 40 and 60 beats a minute. What if both the SA and AV nodes fail? And this can happen. We have one other failsafe, and that's the Purkinje fibers. They're the last failsafe from that perspective, and the Purkinje fibers can take over to pace the heart. Now, the rate is somewhat slow at 20 to 40 beats a minute, but it'll keep us alive until we can fix things. All of these areas of automaticity, every single one of them, are influenced by the sympathetic and parasympathetic nervous systems. If the parasympathetic stimulation dominates, the heart rate slows, and if sympathetic stimulation dominates, the heart rate's going to be faster. Excitability refers to how well the myocardial cell responds to stimuli or outside stimuli. Now, it's good for the myocardium to respond to the electrical signals meant to pace the heart, but not so good if we have irritable cells and we're responsive to other foci. We tend to get dysrhythmia, and we can see that with conditions that cause ischemia or if we have electrolyte abnormalities. Conductivity is the ability of the cardiac cells to receive the electrical stimuli and conduct the impulse onto the next cell, and of course that's a good thing. Contractility refers to the response of the myocardium. Our response to depolarization is that muscle cells shorten, and that causes contraction that moves volume forward. Remember, once again, a couple things. Contraction needs an electrical stimuli, but even with an electrical stimuli, there's no guarantee we're going to get contraction. Now, these words, these terms should sound familiar to you. You've actually been learning about them as you talked about cardiac medications that you're giving to patients. And I know you started in block 1, looking at medications like digoxin. So some medications like dig work by altering these properties. For example, dig and other medications like digoxins, for example, dobutamine, are what are called positive inotropes. They increase the strength of contraction. Beta blockers are negative inotropes. They decrease the force of contraction and decrease workload on the heart. Beta blockers will also slow conduction, And then we know that antidysrhythmics can affect automaticity and excitability. Sometimes antidysrhythmics will also affect contractility and even, the speed of conduction through the heart. So what is an EKG or ECG, electrocardiogram? It's a graphic recording of electrical activity that's generated by the heart. A guy named Einthoven figured out how to do this way back in the early 1900s. It was like 1901. EKG is a really helpful assessment tool. As you can see, it can help diagnose a bunch of stuff: conduction abnormalities, dysrhythmia, cardiac hypertrophy or enlargement, pericarditis, which is an inflammation of the pericardial sac, electrolyte imbalances, and very importantly, a heart attack. Now, it's a good tool. I mean, it's a piece of assessment as a diagnostic, but EKGs always have to be interpreted in conjunction with clinical findings. Very, very, very important that you remember that we always treat the patient, not the EKG. Also very important, I mentioned this before, electrical activity precedes mechanical activity. You got to have that stimulus. But once again, it bears saying, electrical activity can occur without being followed by mechanical activity. That means you could have a patient that's got a picture-perfect sinus rhythm on the monitor, but that patient is unresponsive and has no pulse. They are dead. That's what we term PEA, or pulseless electrical activity. That's where we have a rhythm on the monitor that we expect perfusion, but the patient is clinically dead. When we look at EKG tracing, you see that it's printed out on paper with a bunch of little tiny squares and some bigger squares. Now, EKG printouts can be strips that spit out from a defibrillator, or it can be your standard 8.5 by 11 inch paper that has multiple leads. Whatever way it's printed, the information that's provided by all of those little boxes is the same. Now, when we look at this, the vertical axis, which is the up and down axis, that is voltage. That measures voltage, and that's not something we're going to be concerned about for the most part as we look through things. We're going to be paying attention to the horizontal axis. The horizontal axis across the strip measures time, and that's what we're going to focus on. So you see that we have these teensy-tiny little baby boxes. These are little 1 millimeter baby boxes, and then you see that 25 of them, 5 by 5, are outlined. And then we've got an outline that's taken and blown up here. So I always call these little itty-bitty boxes the baby boxes, and then we've got the big boxes. Now, of course, that's not the technical term, but that's what I always talk about, and so that's what I'm going to be referring to as we talk through this. Now, remember, we're going to focus on the horizontal axis. Each little baby box across that box, remember, horizontally across that box, is time. And each little baby box represents 0.04 seconds of time. That's not a lot of time. When you look at the group of 5 boxes across, so we're looking horizontally again, if each baby box represents 0.04 seconds, when we multiply that times 5, across here, those 5 baby boxes represents 0.2 seconds worth of time. So it makes it just a little bit easier, okay? Now, just worth mentioning because it's here, the vertical is voltage. Each little baby box represents 0.1 millivolts when we look at voltage. This is what's called a 6-second strip. We're going to start at the bottom left corner. Again, just kind of a review. Why is that 6 seconds? And you'll see some markers on here. A lot of strips will have hash marks either across the top or the bottom. And when we see them like this, what this is showing you is what's called a 3-second interval. So from here to here represents 3 seconds in time. We're going to talk about estimating heart rate, and we're going to use a 6-second strip in order to do that. In order to get our 6 seconds, we would need to go from here to get 6 seconds. So how did we get there? Once again, remember each little baby box across the horizontal axis is 0.04 seconds. Each larger box is 0.2 seconds. 5 larger boxes is 1 second. So how do we get there? So remember, this is 0.2, so this is 0.4, 0.8, wait a minute, 0.2, 0.4, 0.6, I can count, 0.8, 1 second, okay? And then you also see that 15 of those larger boxes put together gives us 3 seconds. So 5 large boxes, 1 second, 15 large boxes, 3 seconds. Once again, why am I going to make you guys look at the time? Now, you see monitors with EKG displays, or you look at printed EKG strips, and you know the heart rate is typically displayed or printed. The monitor, though, is sometimes just not that smart about picking up on artifact and things like that could give you an incorrect rate. For that reason, it's always a really good idea to know how to estimate heart rate. And because I want to reinforce the concept of time on the strip, I'm going to make you calculate some heart rates. I deliberately took them out. An easy estimate that works whether the rhythm is regular or irregular is the 6-second strip method. Some printouts like this one, so you look for the slash marks, or you can make yourself a 6-second strip ruler, whatever you want to do. But this is a fairly easy method. In the 6-second strip method, you count waveforms within that strip and you multiply it by 10 to get 60 seconds. I don't have any waveforms on this strip, so let's go to the next one and try it out. Okay, we have waveforms here, and we want to estimate the heart rate. I don't have a heart rate indicated, so look at the strip and find 6 seconds. Now, this one has some additional hash marks. So you've got these bold hash marks here to here, that is 3 seconds. And so you got another one here. So your 6 seconds is going to be this entire strip. Okay. Now this one also gives you the, the 1 second. And so remember, here to here is 0.2, 0.4, 0.6, 0.8, 1 second, 2, 4, 6, 8, 2 seconds, 2, 4, 6, 8, 3 seconds. All right, so we have located 6 seconds worth of strip. Now what you're going to do is you're going to count complexes. We can count, now you're going to count, waveforms, not a complex. You're going to count either P waves. Now P waves are the little bump that's right here. Here's a P wave, P wave, P wave, and we'll get into explaining those. Or you count QRSs. Now, I like to count the QRSs for a couple reasons. One, QRSs are bigger than P waves, and it's just easier to see. Besides that, a patient can have an EKG without a discernible P wave and be okay. But if you're looking at a strip and the patient doesn't have a QRS, well, they're dead, and counting heart rate really isn't the priority at this moment in time. Anyways, let's get back to counting. So I have my 6 seconds, and I'm counting the complexes within 6 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9. I have 9 complexes in 6 seconds. I need 60 seconds, so I multiply that 9 by 10 to get 60 seconds, and so I'm estimating that the heart rate is approximately 60 beats a minute. It's not exact, but it gives you, give or take, probably 5 beats either way. Now, your textbook mentions a method whereby you count those teeny tiny baby boxes from one QRS to the next, and then you take that number and divide the number of baby boxes into 1,500. And yikes, that's too much math for me. And too tiny a baby boxes, and it's only going to work if the rhythm is regular. If it's irregular, then you can't use that method. A little more terminology that we'll be talking about. We mentioned depolarization. Remember that depolarization is essentially a wave of positively charged sodium ions that rush into myocardial cells, changes the pressure, the electrical gradient from negative to positive, and that stimulates contraction of the myocardium. As sodium moves into the cells, potassium has to shift out. Now, certain AV nodal cells use calcium to help with depolarization. So potassium, sodium, and calcium are very important, electrolytes for depolarization and repolarization. Repolarization is a return to a normal resting state for that myocardial cell. And that means that ions have to be put back where they belong. Sodium has to be actively pumped out of the cell, and potassium has to be pumped back in. So repolarization requires energy to fuel the ATP pumps that are responsible for doing that. and that energy needs to be in the form of oxygen and glucose. That gets problematic if the patient is hypoxic or ischemic or infarcting. And that's part of the reason that we see EKG changes with, for example, heart attack. The term baseline refers to a state of readiness. It's the starting or resting line of the EKG. There's nothing that, there's no electrical activity that's measurable. And so we refer to it as isoelectric because it's that point where no measurable depolarization or repolarization is occurring. The term wave means any deflection from that baseline or that isoelectric line. That wave can be upright, and that's termed a positive deflection. And it occurs when a wave of depolarization is moving toward a positive electrode that's, stuck on the patient. Negative deflections occur when the waveform points downward. And then sometimes you see waveforms that have both positive and negative components, and we term that biphasic. Here's our EKG complex. It starts out with a P wave, all right? And that's what's green here. That's our P wave. What does it mean? And by the way, complex, the EKG complex should include three, different waveforms: the P wave, the QRS, and the T wave. So here's our P wave. The P wave represents atrial depolarization. So somewhere right around here, before the P wave, the SA node fired. And remember that SA node sets off waves of depolarization in the atria, and atrial contraction should occur. So this is the wave of depolarization that's measurable, moving through the atria. Contraction always follows electrical. So here's electrical contraction of the atria is occurring right here, okay? Now the P wave should be upright and rounded like this one. It shouldn't be upside down. It shouldn't really be biphasic. What you see here in yellow that says PR, it's part of what's called a PR interval measurement. This little bit is an example of that isoelectric state. There's nothing measurable in terms of depolarization or repolarization going on, and so it's at baseline. Baseline, you actually can take, and this is a point where there's nothing going on electrically, and so if you trace this line across the complex, it should be straight across. Every time we've got nothing electrical going on, we should return to that baseline, to that isoelectric state. And so within the complex, this little chunk after the P wave and before the QRS, and this chunk here after the S wave and before the T wave should be isoelectric, okay? All right, so we do some measurements that we're going to be talking about in the next part here that tell us, we do measurements across the horizontal axis that help us figure out how well the conduction is working, and we'll get into that. All right, our next complex is our QRS. Now, our QRS represents ventricular depolarization. It's big because we have so much muscle mass in the ventricle, particularly the left ventricle. There are actually three separate waveforms here. This first downward wave is your Q wave, and the Q wave is always the first downward wave. The next wave, the first upward waveform, is the R wave. So this is my R wave, and then the downward waveform that follows that is the S wave. Now, so this does actually have a Q, R, and S wave. Sometimes you'll see a waveform that does not have a Q wave. It just starts out with the R wave, and basically we have an RS. That'll get important if you take a 12-lead EKG class to kind of look at that. It's sort of picky, but for us, we just refer to this whole chunk, regardless of whether it's got the Q wave or not. We refer to it as QRS. Now, after the QRS, you see this is labeled the ST segment. This isn't a waveform. This is an isoelectric time between ventricular depolarization and repolarization, and it should be at baseline. And so we look to make sure that it's at baseline. The last waveform that we would see typically is the T wave. Now, the T wave it represents ventricular repolarization. And remember, that's where sodium, potassium, and calcium ions are moved back to where they belong, and it requires energy. And so when we see wonky T waves should be upright and rounded. And when we see T waves that don't look like they should, then that has something to do with the fact that we're having problems repolarizing. And so sometimes we'll see changes in both ST and T wave because of the fact that the heart attack has created issues with oxygen and glucose. All right, you have reached the end. Sorry, I've got a dog that's talking. You've reached the end of Preclinical Lab Packet 1, Part 1. So be sure, take yourselves a little break, and be sure to listen to Part 2 also before you come to Preclinical Lab. And I will see you then.